The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Now let's discuss the thorax, starting with the thoracic wall. So the bony thorax is made up of your sternum, ribs, and thoracic vertebrae. Starting with the sternum, you have first your manubrium, which has a jugular notch at its superior margin, a clavicular notch at the sides, which articulates with the clavicles, and it also articulates with the costal cartilages of the first and upper half of the second ribs. So it's not just the whole of the second ribs. It's just the upper half. And the sternum, it also articulates with the sternum at the sternal angle. So ito yung manubrium, ito yung body of the sternum. Sa sternal angle, dun siya nag-articulate. So the sternal angle is also known as your manubriosternal joint. It is a very important landmark. So take note of all of these structures that passes through or are at this level. So that it's also known as your transverse thoracic plane. It's at the second rib. It is where the T4, T5 intervertebral disc is located. It's the transverse thoracic plane, which separates the superior and inferior mediastinum. It marks the beginning and end of the arch of the aorta. It marks the carina of the trachea, which is the bifurcation to the left and right primary bronchi. It is also where the azygous vein drains into the superior vena cava, and it's where the pulmonary trunk divides into a right and left pulmonary artery. So the body of the sternum articulates with the 2nd to 7th costal cartilages. And it also articulates with the xiphoid process, this one, at the siphisternal joint. And this is at T9. And now the xiphoid process, take note that it completely ossifies only when you're at 40. It lies at T10. So kung yung siphisternal joint ay sa T9, si xiphoid process nasa T10. It's the lower limit of the anterior thoracic cavity. It marks the upper surface of the liver. It's where the diaphragm is located. It is also where the lower border of the heart is located. And the caudal end, this very end right here, is attached to the linea alba. Next, you have the ribs, which are 12 pairs of flat bones. You have 3 classifications. You have your true ribs or your vertebrosternal ribs. You have your false ribs proper, which are your vertebrochondral ribs, and your floating ribs. Kaya siya true ribs kasi they are attached to the sternum by their costal cartilages. Kaya siya vertebrosternal. So from the vertebral column to the sternum. Yung false ribs proper, kaya siya tinawag na vertebrochondral kasi they are just attached to the costal cartilages of those ribs immediately above. And yung floating ribs, they're only connected to the vertebrae. So the 1st to 7th are true ribs, the 8th to 10th are your vertebrochondral, and your floating ribs are your 11th and 12th ribs. So the ribs have many parts. So first, you have the head, and it has 2 articulating facets for articulation with the corresponding vertebral body and that of the vertebra immediately above. So for example, you have the 5th rib. If you take into account the 5th rib, the head of the 5th rib is articulated with the body of T4. So the and the body of T5. So the corresponding vertebral body and the one above, immediately above. Next, you have the neck, which is found between the head and the tubercle. So this is the head, this is the neck. Next, you have the tubercle. This is the tubercle. And it has a facet that articulates with the transverse process of the numerically corresponding vertebra. So, yung 5th rib, dito sa example, The tubercle articulates with the transverse process of T5. Okay? So head articulates with the body, head of the rib articulates with the body of the vertebra. The tubercle articulates with the transverse process. And then you have the shaft or body. It has a costal groove which follows the inferior and internal surface of the rib, and it is where you can find your intercostal vessels and nerves. So ribs can also be classified into typical or atypical. So your 3rd to 9th ribs are your typical ribs because they have heads, necks, tubercles, and bodies. Yun na-discuss natin kanina. So the first rib is atypical because it has only a single articular facet on its head which articulates with the first thoracic vertebra. Meron din siyang scalene tubercle for the anterior scalene muscle, and it has grooves for the subclavian artery and vein. The second rib is atypical because it has a tuberosity for the serratus anterior, and its 2 articular facets on the head articulate with the bodies of the first and second thoracic vertebra. The 10th rib only has a single articular facet on the head articulating with the 10th thoracic vertebra, and the 11th and 12th ribs only have a single articular facet on the head, and they have no necks or tubercles. So it's the first rib over here, the second rib, the 11th and 12th ribs. So the first rib has a lot of important relations with other structures. So here in this image, this is the attachment of the anterior scalene. And we can see here that anterior to the anterior scalene, the subclavian vein crosses the rib. And posterior to the anterior scalene, the subclavian artery and the lower trunk of the brachial plexus crosses the rib. So inside the thoracic wall is your thoracic cavity, which is also called your chest cavity, enclosed by the ribs, the vertebral column, and the sternum. It is separated from the abdominal cavity by the diaphragm. So dito yung abdominal cavity, ito yung thoracic cavity. It contains the heart and the lungs, the great blood vessels, the esophagus, trachea, thoracic duct, and neurovascular structures supplying the visceral parts of the thorax. So the thoracic outlet, also called your anatomical thoracic inlet, is where the thoracic cavity communicates with the root of the neck. So yung boundaries niya is the first thoracic vertebra, so T1, and then the medial border of the first rib, and then the manubrium anteriorly. It is where it's where important vessels and nerves emerge from the thorax to enter the neck and upper limb. So nakita natin lahat yung mga subclavian, artery and vein, yung mga nerves. They exit the thorax to enter the neck and upper limbs. So when the brachial plexus and the subclavian artery and vein are impinged between the first rib and clavicle, you have thoracic outlet syndrome. So the symptoms caused by pressure on the lower trunk of the plexus produce pain down the medial forearm and hand, causing wasting of the hand muscles, and the pressure of on the blood vessels can compromise the circulation of the upper limb. So some of the movements of the thoracic wall include changes to the vertical diameter. So when the diaphragm moves down or when it contracts, the vertical diameter increases. So bababa si diaphragm. So mag-increase yung vertical diameter ng thoracic cavity. But when the diaphragm goes up, when it relaxes during expiration, the thoracic cavity decreases in vertical diameter. Other movements, movement of the transverse diameter, it's known as your bucket handle movement. So the pail handle is raised and its convexity moves laterally, as we see here in figure A. So sa ribs, ito yung magiging itsura niya. So the axis of movement is that it increases the transverse diameter. So what happens is that intercostal muscles contract on inspiration and the ribs move laterally and increase the transverse diameter. You also have anteroposterior diameter increasing with the changing with the pump handle mechanism. So it increases when the sternum moves up during inspiration. So pag umangat tong sternum, lalaki yung AP diameter. Lalaki tong AP diameter. And it decreases when the sternum moves down, such as with expiration. Key muscles of the thoracic wall include your serratus posterior, your levator costarum, and your intercostals. And you also have your subcostal and your transversus thoracis. So when your intercostals elevate the ribs, they are for so when these muscles elevate the ribs, they are for inspiration. Whereas when they depress the ribs, they cause expiration. Kasi nga, di ba, dun sa bucket handle movement. For the neurovasculature, remember that the intercostal veins, arteries, and nerves are located in the costal groove. It's in the inferior interior surface of the ribs. Remember, it's van, so superior to inferior. So you have the vein, artery, and nerve. So ito, vein, artery, then nerve. So if you do thoracentesis and you have to go through all these layers, you need to insert the needle above the rib to avoid injury to these structures kasi nasa inferior margin yung costal groove. So for the intercostal nerves, you have 11 intercostal nerves and 1 subcostal nerve. Then the 11 intercostal nerves are from the anterior rami of the T1 to T11 nerve, spinal nerves. So hanggang 11th rib. Pero pagdating mo sa 12th rib, subcostal na siya. So technically, parang below the ribs kasi. So it's from the T12 anterior ramus and it's found at the inferior border of the 12th rib. Remember that you also have the intercostobrachial nerve, which is a cutaneous branch of the second intercostal nerve that supplies the upper medial side of the arm. And this is usually where referred pain occurs in coronary artery disease. For intercostal arteries, you have the internal thoracic artery, giving off your anterior intercostals, and you have your aorta, your thoracic aorta, giving off your posterior intercostals and subcostal artery. So the internal thoracic artery, remember, it's from the first part of the subclavian. So ito yung brachiocephalic trunk, magsisplit siya, ito yung common carotid, ito to subclavian na. This one, this first part of the subclavian gives off this internal thoracic artery. And this one gives off your anterior intercostals. And once it reaches your 6th rib, it divides into your superior epigastric and musculophrenic arteries, which also give off anterior intercostals. So your anterior intercostals, your 1st to 6th, arise from your internal thoracic, while your 7th to 9th arise from your musculophrenic. So kapag nag-divide na si internal thoracic, dun lalabas si 7th to 9th anterior intercostals. Sa likod naman, your posterior intercostals, the 1st and 2nd actually arise from the superior or supreme intercostal artery. At saan galing to? Sa costocervical trunk of the subclavian artery, the second part of the subclavian artery. While the 3rd to 11th actually arise from the thoracic aorta. So yung 1st and 2nd, galing sa supreme or superior intercostal. Galing pa siya sa subclavian. Pero yung 3rd to 11th, galing na siya sa thoracic aorta. And just like your subcostal nerve, your subcostal artery is found at the inferior border of the 12th rib. So basta below all the ribs na, subcostal siya. And it's from the thoracic aorta as well. For the intercostal veins, the anterior intercostal veins follow the corresponding arteries. So, nagdrain sila into the internal thoracic and musculophrenic veins. Your posterior intercostal veins, the first directly drains into the brachiocephalic vein. Your 2nd and 3rd unite to form the superior intercostal vein. So, for example, here, the right superior intercostal vein drains into the azygos vein, while the left superior intercostal drains directly into the left brachiocephalic vein. The 4th to 11th posterior intercostals drain into your azygos or hemiazygos veins. Now your subcostal vein, again found at the inferior border of the 12th rib, they actually join the ascending lumbar veins to form your azygos and hemiazygos veins. For example, here on the right, you see the subcostal vein. It's joining this vein over here, which is the lumbar vein. And here, behind the inferior vena cava, that's your azygos vein. While the left, it joins the left ascending lumbar to form your inferior hemiazygos vein. So si azygos nasa right, si hemiazygos nasa left. For the lymphatics of the thorax, the thoracic duct drains most of the body. So everything here that's seen as red, it's actually drained by the thoracic vein. Lahat ng iba na green, that's drained by the right lymphatic duct. So, tandaan lang na right lymphatic duct ang kasama dyan, right side of the head and neck, right side of the thorax, and right upper limb. Lahat ng iba, thoracic duct na. So, the thoracic duct actually begins in the abdomen at the cisterna chyli. So, here in the abdomen, this is the cisterna chyli, it passes through the aortic hiatus of the diaphragm at T12, and it ascends through the posterior mediastinum between the aorta and the azygos vein. So ito yung aorta, nasa may left, and your azygos again is at the right. And it runs behind the left internal jugular vein and empties into the junction of the left internal jugular and subclavian veins. So ito si IJV, at ito si subclavian. So lymphatic drainage of the thoracic wall. So you have your parasternal or internal thoracic nodes. So internal thoracic nodes, they just follow the internal thoracic artery. However, it's important to note that they do receive lymph from the medial portion of the breast, and they drain into the junction of the internal jugular and subclavian veins. Your intercostal nodes, on the other hand, are near the heads of the ribs, and they drain into the cisterna chyli. While your phrenic nodes are found on the surface of the diaphragm, and they drain into your parasternal and posterior mediastinal lymph nodes. So here's a diagram of your parietal nodes of the thoracic wall. You have your sternal, intercostal, and diaphragmatic. For the visceral lymph nodes, on the other hand, your thymus and pericardium drain into the anterior mediastinal nodes. Your esophagus and sternal lymph nodes drain into your posterior mediastinal nodes, while your trachea, bronchi, lungs, and heart, so most of the viscera, drain into your tracheobronchial nodes. Now, these drain into your right and left tracheomediastinal trunk, which divide or drain into your right lymphatic trunk on the right, and for the left, it drains into the thoracic duct. But your posterior mediastinal nodes drain directly to the thoracic duct. Now we go to the mediastinum. So the mediastinum is the central compartment of the thoracic cavity. It is divided by an imaginary plane passing from the sternal angle to the T4-T5 IV disc into a superior and inferior mediastinum. So this is the superior and this is the inferior. So above is the thoracic inlet, below is the diaphragm. Anteriorly, you have the sternum, and posteriorly, you have the bodies of the thoracic vertebra. The inferior mediastinum is further subdivided into an anterior, middle, and posterior mediastinum. So we'll be discussing the contents of each. So for the posterior mediastinum, it's bounded by the thoracic inlet above, the transverse thoracic plane below, anteriorly by the manubrium, and posteriorly by the bodies of the thoracic vertebra, so from T1 to T4. It contains the thymus gland, the superior vena cava, the brachiocephalic veins, the arch of the aorta, trachea, esophagus, the vagus nerve, left recurrent laryngeal nerve, the phrenic nerve, thoracic duct, lymph nodes, and the sympathetic trunks. For the anterior mediastinum, it's bounded superiorly by the transverse thoracic plane, below by the diaphragm, anteriorly by the body of the sternum and the xiphoid process, and posteriorly by the heart. It contains fat, loose connective tissue, lymph vessels, and lymph nodes, branches of the internal thoracic vessels, syempre dyan pupunta, from the subclavian, pababa. And its continuation, and sometimes it contains the continuation of the inferior thymus in children and infants. For the middle mediastinum, it contains the pericardium and the heart, the ascending aorta, the superior vena cava, inferior vena cava, the brachiocephalic vessels, pulmonary vessels, the trachea and the main bronchi, and the phrenic, vagus, and left recurrent laryngeal nerves. Remember, the right recurrent laryngeal nerve loops at the subclavian, so hindi na siya makikita dito. And lastly, you have the posterior mediastinum bounded by the transverse thoracic plane and superiorly, inferiorly by the diaphragm, anteriorly by the posterior border of the heart, and posteriorly by the bodies of the thoracic vertebra. And it contains the esophagus, the thoracic aorta, your azygos, again sa right, and your hemiazygos sa left, veins, the thoracic duct, your vagus nerve, sympathetic trunks, splanchnic nerves, and lymph nodes. Next, we go to the pericardium. So your pericardium is actually divided into an inner serous layer and an outer fibrous layer. And your inner serous layer is further divided to an inner visceral and outer parietal layer. So here you can see that the serous pericardium is composed of your parietal pericardium and visceral pericardium. So you have pericardial nerves, which supply sensation to the pericardium. You have the phrenic nerves, C3, again, from the C3 to C5 nerves, and they are the primary source of sensory fibers. So, pain sensations commonly refer to the skin of the ipsilateral supraclavicular region. You also have vagus nerve, however, the function is uncertain, and sympathetic trunks for vasomotor function. An important clinical correlation is cardiac tamponade. So there's accumulation of fluid in the pericardial cavity. So what happens is that there's compression of the heart chambers. So if you compress the heart chambers, wala masyadong blood na babalik or walang masyadong blood na makakapasok. At dahil bababa si venous return, bababa din yung blood na mapapump out of the heart. So pag bumaba si venous return, bababa din si cardiac output. And pericardial effusion may result in Kussmaul's sign, which is distension of the veins of the neck on inspiration. And how do you resolve pericardial for cardiac tamponade? You do pericardiocentesis. So it's used to drain fluids from the pericardial cavity. So one approach is the substernal approach. So the needle is inserted at the left, fifth, or sixth intercostal space near the sternum. And when you do this, you pass through skin, fascia, the rectus sheath, the rectus abdominis muscle, then the fibrous layer of the parietal pericardium, and then the serous layer of the parietal pericardium. And once you puncture the serous layer, pwede mo nang ma-aspirate yung fluid. Now let's go to the heart. So the heart is shaped like a tipped over pyramid with an apex pointing anterior and to the left, a base which is opposite the apex, and it has four sides. So ito, to the left, pointing to the left, and anterior. Ito yung base. As you can see here, ito yung pyramid. Tapos ito yung base, pagdignan from the posterior aspect. So the apex is formed by the inferolateral part of the left ventricle. So this one. And it is found posterior to the fifth intercostal space, left midclavicular line, where you can hear the apex beat. So the base is mainly formed by the left atrium and a little bit from the right atrium. The heart has four surfaces. You have your anterior or your sternocostal surface formed by the right ventricle, a diaphragmatic surface formed mainly by the left ventricle and partly by the right ventricle, a right pulmonary surface formed by the right atrium, and the left pulmonary surface formed by the left ventricle. So the heart also has four borders. The right is formed by the right atrium. The inferior border is formed mainly by the right ventricle and partly by the left ventricle. The left border is formed mostly by the left ventricle and partly by the left auricle. And the superior border is formed mainly by the right atrium and left atrium. So clinical correlation of those borders or the concepts that we discussed is the cardiac silhouette on chest X-ray. So the heart casts most of the central radiopaque shadow in PA projections. So the right border, seen here, is made up of your right atrium, and you have a bit of the superior vena cava and inferior vena cava. The left border is made up of your arch of the aorta, your pulmonary trunk, the left auricle over here, and your left ventricle. So what takes up most of this space would be your right ventricle. Again, it's mostly the sternocostal surface of the heart. For the heart valves, you have the tricuspid, mitral, aortic, and pulmonary valves. Each of the tricuspid, kaya siya tri kasi tatlo yung cusps. Kaya siya tricuspid kasi tatlo yung cusps niya, the anterior, inferior, and septal. Your mitral is also known as your bicuspid valve, so it has an anterior and posterior cusp. Your aortic and pulmonary all have three cusps. Both have three cusps. So right, left, posterior for the aortic, and for the pulmonary, it's right, left, and anterior. Magkaiba yung surface anatomy sa auscultatory area nila. What's important is the auscultatory area clinically. So for the tricuspid, it's at the right half of the lower end of the body of the sternum. So nandito sa area na to. For the mitral, it's at the fifth intercostal space, left mid-clavicular line. It's where the apex of the heart is. That's where you hear the apex beat. For the aortic, it's at the medial end of the second right intercostal space. And then your pulmonary valve, it's at the medial end of the second left intercostal space. Remember that during systole, what valves are open? It's your aortic and pulmonary valves. Your tricuspid and mitral valves are closed. But in diastole, the tricuspid and mitral valves are open, while it is your aortic and pulmonary valves that are closed. So the vasculature of the heart are the coronary vessels. For the arterial supply of the heart, you have the right coronary artery and the left coronary artery. So the right coronary artery has the SA nodal artery, the right marginal artery, and the posterior interventricular artery, and the AV nodal artery. For the left coronary artery, it divides into your circumflex artery and your anterior interventricular artery. So the circumflex artery gives off your left marginal artery, and in 40% of people, your sinoatrial nodal artery. So this picture shows what areas of the heart are supplied by which artery. So your left circumflex supplies the left atrium and left ventricle. Your right coronary supply the right atrium and the right ventricle. Your right marginal artery, which is a branch of your right coronary, supplies the right ventricle and the apex. Your left anterior descending or left interventricular or anterior interventricular artery supplies the right ventricle, left ventricle, and your IV septum. And your left marginal artery supplies the left ventricle. This is all on the anterior. Posterior. When you look at the posterior, the left circumflex artery supplies the left atrium and ventricle, the left marginal artery, the left ventricle, the right marginal artery, the right ventricle and apex, and you have your posterior interventricular artery, which supplies the right and left ventricles and also the IV septum. And of course, your right coronary artery supplies the right atrium and the right ventricle. So there can be variations in coronary arteries. And when you say coronary artery dominance, it's when it refers to the variable origin of the posterior interventricular artery. So, if you're right dominant, which is 67% of the population, the posterior interventricular artery is a branch of the right coronary artery. If you're left dominant, then your posterior interventricular artery is a branch of your left coronary artery. And in the remaining population, it's codominance, wherein the posterior interventricular artery is a branch of both the right and left coronary arteries. For the venous drainage of the heart, you have the coronary sinus and its tributaries. And a mnemonic is GSMO or GISMO. So you have the great, small, middle cardiac veins and your oblique. You also have the anterior cardiac vein and your Thibetian veins, your venae cordis minime. So these open directly into the right atrium. So here you have the coronary sinus, you have your small cardiac vein, your middle cardiac vein, and here your great cardiac vein. So this slide shows a simplified diagram of the venous drainage of the heart. So you have your G, S, M, and O draining into the coronary sinus, your coronary sinus, anterior cardiac vein, venae cordis minime, and your superior vena cava drain into the right atrium. So, for example, you have thrombosis of the coronary sinus. Which vein is not implicated or is not affected? If you're given these choices, 1, 2, 3, and 4, the answer is your anterior cardiac vein because it does not drain into the coronary sinus. So your coronary arteries and veins are closely related to each other. Your great cardiac vein is associated with your anterior interventricular artery, your middle cardiac vein to your posterior interventricular artery, and your small cardiac vein to your right marginal artery. Yung itsura nila, ito yung heart. Dito si anterior interventricular, andito din si great cardiac vein, andito si right marginal artery, andito rin si small cardiac vein, tas sa likod, andito si posterior interventricular artery, andyan din si middle cardiac. So for the lymphatic vessels of the heart, they receive lymph from the myocardium and epicardium, and they follow the right coronary artery, and they empty into the anterior mediastinal node. And for the left coronary artery, they empty into the tracheobronchial node. So for the nervous system of the heart, the autonomic nervous system is via the cardiac plexus. And you have the sympathetic and parasympathetic nerves. So for the sympathetic nerves, it's from the lower cervical and upper thoracic ganglia. It increases the rate and ventricular contraction, and it dilates your coronary vessels. For parasympathetic innervation, it's from the vagus nerve. It decreases your heart rate and ventricular contraction, and it constricts the coronary vessels. Another important structure would be your conducting system, found at the subendocardial layer and adjacent myocardium. And these are made of modified cardiac muscle cells. So we start with the sinoatrial node, and the impulse travels to your atrioventricular node found at the interatrial septum at the apex of Koch's triangle. It now goes to the bundle of His, which is found at the membranous portion of your interventricular septum, and it divides into your right and left bundle branches, which is now found in the muscular portion of the IV septum, and then it goes to divide into your Purkinje fibers. So for the placement of ECG leads, your V1 is just right of the sternum, your V2 is at left of the sternum, your V3 is midway between V2 and V4, your V4 is at the midclavicular line, your V5 is at the anterior axillary line, while your V6 is at the mid-axillary line. So yung madaling tandaan dito is yung V4, V5, V6 kasi if na-follow niyo yung lines, your V2 is just left of the sternum, your V1 is just right of the sternum, tapos si V3 just midway between V2 and V4. So for cardiac referred pain, it's when noxious stimuli originating in the heart are perceived by a person as pain arising from a superficial part of the body. Usually, it's over the T1, T5 dermatomes. So the pain can also radiate to the left shoulder and the medial aspect of the left upper limb, again because of your medial cutaneous nerve joined or overlapped by the intercostobrachial nerve, which is a branch of your second intercostal nerve. So for myocardial infarction, it results from localized avascular necrosis of cardiac muscle caused by prolonged ischemia. So the most common sites of coronary artery occlusion would be your anterior interventricular artery, followed by right coronary artery, then your circumflex branch of the left coronary artery. So infarcts and ECG. So if the artery block is the proximal left anterior descending or your anterior interventricular, then you have a large anterior wall infarct, and it will be seen as ST elevation in leads 1, AVL, V1 to V6. If it's more distal, if it's anteroapical, then at the apex, so it will be picked up by leads V2 to V4. If it's at the inferior wall, so inferior at the floor, it will be leads 2, 3, and AVF. If it's distal left anterior descending, it's anteroseptal, so it's going to be picked up by V1, V2, and V3. If it's the circumflex, it's posterolateral, so lateral and posterior, it's going to be picked up by your V4, V5, and V6 leads. A quick discussion on the development of the heart. So your heart starts as a tube which elongates and develops dilatations and constricts, and it also twists around. So your fetal structures include your primitive atrium, which become your left atrium. Your sinus venosus splits into a right and left horn. The right horn becomes the right atrium, while the left horn becomes your coronary sinus. The primitive ventricle becomes your left ventricle. The bulbus cordis becomes your right ventricle, and your truncus arteriosus becomes the root of both the aorta and the pulmonary trunk. So for fetal circulation, you have several fetal structures which disappear or change once the baby is born. So your left umbilical vein becomes the ligamentum teres or the round ligament of the liver. Your ductus venosus becomes the ligamentum venosum. Your umbilical arteries become the right and left medial umbilical ligaments of the urinary bladder. Your foramen ovale closes and becomes your fossa ovalis found at the right atrium. And your ductus arteriosus becomes the ligamentum arteriosum. Now we'll discuss the pleura. So the pleura has two layers. Your parietal layer, which lines the thoracic wall, and your visceral layer, which lines the outer surface of the lung and even extends into the interlobar fissures. So the parietal pleura has four parts, your costal, mediastinal, diaphragmatic, and cervical parts. So yung cervical, sa may neck, Yung costal, yung nakadikit sa ribs. Mediastinal, yung nakadikit sa gitna or sa yung medial part. And your diaphragmatic, it's the inferior part. Closely related to the diaphragm. The cupula is the cup-like dome over the apex that actually reaches 2 to 3 centimeters superior to the level of the medial one-third of the clavicle. So actually, yung pleura, it reaches above the clavicle. An important fascia is the Simpson's fascia, which is a dense fascial layer that is attached to the inner border of the first rib and costal cartilage anteriorly, the C7 transverse process posteriorly, and the mediastinal pleura medially. It overlies the apices of the lungs above the superior thoracic inlet on each side. So your parietal and visceral pleura reach different areas of the thoracic cavity. Your costal line of pleural reflection, which is basically your parietal pleura, reaches the eighth rib at the mid-clavicular line. So ito yung mid-clavicular line. Nakikita natin hanggang eighth rib siya. At the mid-axillary line, so laterally, it's at the 10th rib. And posteriorly, sa sides of the vertebral column, they actually reach the 12th rib. While the lower margin of the lungs, which is basically your visceral pleura, only reaches the 6th rib at the mid-clavicular line. So ito yung lower margin, di ba, ng lung. Hanggang 6th rib lang siya sa mid-clavicular line. Hanggang 8th rib lang siya sa mid-axillary line. And hanggang 10th rib lang siya sa sides of the vertebral column. Ano yung implication niya? Yung space sa pagitan ng naabot ng visceral at parietal pleura can be accessed to gain entry into your pleural cavity. Such as with thoracynthesis, wherein a needle is used to withdraw fluid from the pleural cavity, minsan from the cosodiaphragmatic recess. So the needle is introduced into the pleural cavity at or posterior to the mid-axillary line, 1 or 2 intercostal spaces below the fluid level, but not below the 9th intercostal space. Ano ba yung nasa ilalim ng 9th intercostal space? It's your 10th rib. At sa mid-axillary line, kapag umabot ka ng 10th rib, hanggang doon na lang kasi yung parietal pleura. If you go below that, masasaksak mo na yung, kunwari nasa right, masasaksak mo na yung liver. So it's usually done at the 7th to 9th intercostal space. And again, the needle is inserted immediately above the superior margin of the rib to prevent injury to your intercostal nerves, the neurovascular bundle. So the needle penetrates 7 structural layers: your skin, the superficial fascia, the deep fascia, your intercostal muscles, your endothoracic fascia, the extrapleural fatty layer, and then your parietal pleura. So after the parietal pleura, ma-access mo na yung pleural cavity. The pleura has nerve supply. Your parietal pleura is sensitive to pain, temperature, touch, and pressure. The costal part, yung nakadikit sa ribs, it's via the intercostal nerves. The mediastinal part is via the phrenic nerves. And your diaphragmatic part is via the phrenic and intercostal nerves. The visceral pleura, on the other hand, is only sensitive to stretch, which is supplied by the pulmonary plexus. Now let's go to the lungs. So the lungs mainly function to oxygenate the blood. Healthy lungs are light, soft, and spongy. They are conical in shape, covered with visceral pleura, and the only attachment to the mediastinum is by its root. So it's suspended free in its own pleural cavity. So the lungs have apices and bases. So the apex of the lung can be found 2.5 centimeters above the clavicle. So kung ito yung clavicle, nandito. Yung apex ng lung ay nandito. While the base rests on the diaphragm. You have 3 surfaces: a costal surface, which is convex, a mediastinal surface, which is concave, and a diaphragmatic surface, which is concave. You also have anterior, inferior, and posterior borders. So there are several differences between the right and left lung. Grossly, the right lung is larger, heavier, shorter, and wider. So the left lung is smaller, lighter, narrower, and longer. The right lung is made up of 3 lobes. So you have the superior, middle, and inferior lobes. while the left lung only has two lobes. You have the superior lobe and the inferior lobe. However, your superior lobe has a lingula, and the lingula, which translates to tongue, corresponds to the middle lobe of the right lung. The right lung has two fissures, a horizontal fissure, this one, horizontal fissure, and an oblique fissure, which divides the right lung into the three lobes, while the left lung only has one fissure, because it only has two lobes, just one oblique fissure. For lobar and segmental bronchi, the right lung has 3 lobar bronchi and 10 segmental bronchi, while the left lung only has 2 lobar bronchi and 8 to 10 segmental bronchi. So some grooves. So the right lung has a groove for the superior vena cava, the arch of the azygos vein, and the esophagus. While for the left lung, there's a groove for the arch of the aorta over here, and a groove for the descending aorta. A unique feature of the left lung would be your cardiac impression or notch. So the hilum of the lung is the wedge-shaped area on the central portion of each lung. So this is the hilum. It is located on the medial aspect of each lung, and it's where the root of the lung enters and exits. So take note, magkaiba yung hilum of the lung sa root of the lung. Itong structures na to, ito yung root. Pero itong area na to, yan yung hilum. So the root of the lung is the collection of structures that connect the lung to the mediastinum. And remember, ito lang yung connection ng lung sa mediastinum. Otherwise, it's suspended in the pleural cavity. So the root of the lung includes your pulmonary arteries and veins, your primary bronchi, bronchial arteries or veins, and pulmonary nerve plexuses, and your lymphatics. So your bronchopulmonary segments are pyramidal shaped, wherein the apex is directed towards the lung root. So kung ito yung lung, tas ito yung root, lahat ng bronchopulmonary segment nakaturo papunta dun sa root, and they are pyramidal in shape. It is the largest subdivision of a lobe, and is named according to the segmental bronchus supplying it. It's actually the anatomical and surgical unit of the lung. So again, for your bronchopulmonary segments, your right lung would have 10, while your left lung would have 8 to 10. So the way I remember this is by a little dance. So yung sa right ay, di ba may tatlo sa upper lobe? You have your apical, your posterior, and anterior. While on the left, usually combined yung apico-posterior, so yung thumb nakaturo pa likod. Tapos yung anterior, nakaturo pa harap. So, chang. Then, for the middle part, which is sa superior din, or sa lingula. So, your middle lobe sa right lung is yung, kapartner niya is yung lingula sa left. So, sa right lung, yung middle lobe, you have the medial and your lateral. While sa left lung, sa lingula, you have your superior lingular and your inferior lingular. So, ganyan. And then, for the lower lobe, parehong may 5. So, sa right, you have your superior, yung thumb, nakaturo pa likod, superior. Then, you have the 4 fingers na naka-arrange na lang. Anterior basal, medial basal, lateral basal, and posterior basal. Tapos sa left, you have your lateral basal, your superior, your lateral basal, posterior basal, anteromedial basal. So, usually combined si anteromedial. So, anteromedial. Pwedeng yan, ganyan. So, ganito. So, 4 dito, or pwede rin 5, depende nga kasi 8 to 10. So, pag natago yung pinky, yan, ganyan. So, parang ginagawa ko siyang ganyan, tapos ganyan, tapos ganon. Ayun. Baka lang makatulong sa inyo. Next, you have your bronchi. Your primary then divides into your secondary or your lobar. Then they divide into your tertiary or your segmental bronchi. For your main bronchi, may pinagkaiba din yung sa right at left. Your right main stem bronchi is wider, shorter, and more vertical, and it runs under the arch of the azygos. While for the left main stem bronchi, it runs inferolaterally to the arch of the aorta, and it crosses anterior to the esophagus. So again, the right is wider, shorter, and more vertical. For the lobar or secondary bronchi, your right lung has 3 secondary bronchi, 1 for each lobe. one eparterial, which means it is superior to the pulmonary artery, and two hyparterial, the middle and inferior. For the left lung, both of the secondary bronchi are hyparterial. So for foreign body aspiration, because of the orientation of your bronchopulmonary segments or your segmental bronchi, as well as the orientation characteristic of your mainstem bronchi, foreign bodies are more likely to enter the right main bronchus, again because it is shorter, wider, and more vertical than the left main bronchus. So depende sa position kung kung kailan nag-aspirate, doon magde-depend saan mapupunta. When you're sitting and you're standing, papasok yung foreign body sa posterior basal bronchopulmonary segment of the right lower lobe. Kasi yun yung actually pinaka-diretso pababa. Kasi again, mas diretso yung right main bronchus, di ba? So, punta na nga siya sa right. Yung pinaka-diretso pa yung direction or yung trajectory ay yung posterior basal bronchopulmonary segment. When you're lying supine, again, mapupunta siya sa right lobe. Pero pupunta siya sa superior bronchopulmonary segment. Bakit? Kapag tinignan natin yung dance, di ba ganyan, tapos ganon, tapos ganito. Meron kang yung thumb mo nakaturo talaga palikod posteriorly. So pag nakahiga ka, doon papasok yung foreign body, diretso siya doon. When you're lying on the right side, pupunta siya sa posterior bronchopulmonary segment ng right upper lobe. While if you're lying on the left side, pupunta siya sa inferior lingular bronchopulmonary segment ng left upper lobe. So for blood supply of the lungs, remember that there's a non-respiratory circuit to the lungs. Kasi organ din naman siya. So meron talaga siyang sarili niyang blood supply. And it's the bronchial arteries and veins. So remember, pag tinanong kayo, blood supply to the lungs or brings oxygenated blood to the lungs, may sagot yan. At ang sagot ay bronchial arteries. So they are from the descending thoracic aorta. For the venous drainage, they communicate directly to the pulmonary veins and they drain into your azygos and hemiazygos veins. For the respiratory circuit, ito na yung nagsusupply ng oxygen to the blood. So you have your pulmonary arteries and veins. And your arterial supplies from the pulmonary trunk. Your segmental arteries carry deoxygenated blood into the bronchopulmonary segments, then to your alveoli para ma-oxygenate sila. The left pulmonary artery is shorter and narrower, and it arches over the left primary bronchus, while the right runs under the arch of the aorta. For your venous drainage, you have your intersegmental veins, which then carry the oxygenated blood from the alveoli back to the heart. So they follow the connective tissue septa bounding the pulmonary veins, and then two pulmonary veins leave each lung route to empty into the left atrium. For the nerve supply, you have the pulmonary plexus. So the sympathetic causes bronchodilation and vasoconstriction, while the parasympathetic causes bronchoconstriction, vasodilation, and increased glandular secretion. For the lymphatic drainage flow of the lungs, so to simplify the very complicated picture on the right, just focus on the diagram on the left and use the right image as a guide. So you have the superficial plexus, which is deep to the visceral pleura, and your deep plexus, which is found at the bronchial submucosa and peribronchial connective tissue. So both of these plexuses drain into your bronchopulmonary or hilar lymph nodes. So lahat ng nakikita natin dito sa gitnang to, magda-drain yan papunta sa bronchopulmonary or hilar nodes found at the hilum. So pag sinabi na merong in-extract or kinuhang node from the lungs at the hilum, it's your bronchopulmonary lymph nodes or your hilar lymph nodes. From there, the lymph passes to your superior and inferior tracheobronchial lymph nodes, which is found superior or inferior, depende, to the tracheal bifurcation and main bronchi. So ito yung sa inferior, ito yung sa superior. The lymph then goes, kapag sa right bronchomediastinal lymph trunk, Kapag sa left lung, sa left bronchomediastinal lymph trunk. Tapos kapag sa right, pumunta siya sa right lymphatic duct. Sa left, sa thoracic duct. For the great vessels, we start with the aorta. So you have three parts. You have your ascending aorta, the arch of the aorta, and your descending aorta. So for the ascending aorta, it begins at the aortic orifice and its branches include your right and left coronaries. So right and left coronaries. So syempre yung right and left, sorry. For the arch of the aorta, it's a continuation of the ascending aorta. It lies behind the manubrium and arches forward and backward and then to the left to the front of the trachea. It becomes the descending aorta at the level of the sternal angle. So andito yung sternal angle. So beyond this, below this, naging descending aorta na siya. So the branches include your brachiocephalic artery or trunk, your left common carotid, and your left subclavian. For the descending thoracic aorta, so everything below the sternal angle, it extends from the sternal angle down to the aortic opening of the diaphragm at T12, where it becomes continuous with the abdominal aorta. So branches include your bronchial arteries, your mediastinal, esophageal, your posterior intercostal arteries. Again, your 3rd to 12 intercostal arteries. Your 3rd to 11th intercostal arteries, your pericardial arteries, and your subcostal artery. Next, you have your pulmonary trunk. So this is the pulmonary trunk. It terminates in the concavity of the aortic arch by dividing into right and left pulmonary arteries. So your left pulmonary artery is shorter and narrower than the right. It arches over the left primary bronchus here. That's the left primary bronchus. And it runs in front of the descending aorta. While your right pulmonary artery over here goes behind the ascending aorta and the superior vena cava, and it passes under the arch of the aorta. Next, you have the brachiocephalic vein, which is formed by the union of your internal jugular and your subclavian vein. So at the level of the inferior border of the first right costal cartilage, so dito, drawing natin dito, kunwari ito yung first costal cartilage, the right and left join to form the superior vena cava. Its tributaries include your internal thoracic, so ito, internal thoracic, internal thoracic, your vertebral, inferior thyroid, and superior intercostal. Again, yung superior intercostal, yan yung sa second and third na intercostal vein. So your superior vena cava is again a union of the right and left brachiocephalic veins. It ends at the level of the third right costal cartilage to enter the right atrium. So dito si third right costal cartilage. Third. Papasok na siya sa right atrium. So now let's go to the azygous system. So as we mentioned earlier, yung azygous vein, it's formed by the union of your right ascending lumbar, which is this one, and your right subcostal vein. It ascends through the aortic opening in the diaphragm, which is at T12, on the right side of the aorta to the level of the 5th thoracic vertebra. So nandito si 5th thoracic vertebra. 5th thoracic vertebra. And it arches over the root of the right lung and empties into the superior vena cava. On the left, you have your hemiazygous and accessory hemiazygous veins. So your hemiazygous is again formed by the union of your left subcostal vein and your left ascending lumbar vein. So it ascends on the left side of the vertebral bodies behind the thoracic aorta, and it receives the 9th, 10th, and 11th posterior intercostal veins. So ito, 9th, 10th, and 11th. Tapos si hemiazygous, pupunta na siya sa azygous vein. Your accessory hemiazygous begins at the 4th or 5th intercostal space, descends, receives the 4th or 5th to 8th intercostal veins. So ito siya. And then it descends. So ito si accessory hemiazygous. And it turns to the right, passes behind the aorta, and terminates into the azygous vein. So your posterior intercostal veins, your first posterior intercostal vein drain directly again to your brachiocephalic vein. The second, third, and sometimes fourth join to form your superior intercostal vein. And your superior intercostal vein drains into the azygos on the right. So ito, drains to the azygos on the right. While on the left, they drain into your brachiocephalic. The rest of the veins drain into the azygos on the right and the hemiazygos or accessory hemiazygos on the left. A clinical correlation would be your superior vena cava syndrome, when the superior vena cava is compressed by a lymph node enlargement, usually from metastasis of bronchogenic carcinoma. Because of the blockage of the superior vena cava, blood gets pulled in the areas of the upper limb and also the head. So you have headache, edema of the head and neck, and prominent superficial veins and cyanosis. In complete occlusion, blood is shifted to the tributaries of your inferior vena cava. So that's why you see prominent veins here on the abdomen. We're down to our last two topics. So now we go to the breast, which consists of mammary gland tissue, fibrous and fatty tissue, your vessels, and nerves. It extends from the second to the sixth ribs. So remember, second to sixth ribs. And it extends from the sternum to the mid-axillary line, where you will find your axillary tail of Spence. So the nipple, the adult nipple, is found at the level of the fourth intercostal space. So the mammary gland has suspensory ligaments of Cooper, which are fibrous connective tissue which firmly attach the mammary glands to the dermis. And it functions to support the lobes and lobules of the breast. So there are 15 to 20 lobules which all drain into lactiferous ducts, which then go to your lactiferous sinus and then out the nipple. So for breast fascia, you have the superficial layer of the superficial fascia and you have the deep layer of the superficial fascia. Between the deep layer of the superficial fascia and the pectoralis fascia covering your pectoralis muscles, you will find your retromammary space. And this retromammary space over here allows movement of the breast because it contains loose connective tissue, but it is also a potential space for spread of infections. For the vasculature of the breast, its blood supply comes from the internal thoracic, which is again a branch of the subclavian, from the first part of the subclavian. You have lateral and thoracoacromial arteries from the axillary artery. It also receives blood from the second posterior intercostal, which is from the costocervical trunk, which is from the second part of the subclavian artery. And you have third and fourth posterior intercostal arteries, which are from your thoracic aorta. Your venous drainage, on the other hand, is from the axillary vein and is into the axillary vein and the internal thoracic. For the nerves of the breast, these are derived from the anterior and lateral cutaneous branches of your fourth to sixth intercostal nerves. And the nipple is supplied by the anterior branch of the lateral cutaneous branch of T4. For lymph drainage, this is very important, especially when it comes to breast cancer. Your lateral quadrants over here go to your anterior or pectoral lymph nodes and drain into your axillary lymph nodes. For your medial quadrants, they go to your parasternal lymph nodes or even go to the contralateral mammary gland or the opposite breast. For your inferior quadrants, they go to your subdiaphragmatic inferior phrenic lymph nodes. So we said that the lateral quadrants, the lymph goes to your axillary lymph nodes. Your axillary lymphatics can be divided into 3 levels, depending on their position with respect to the pectoralis minor muscle. So the level 1 lymph nodes are lateral to the pectoralis minor. So this is the pectoralis minor, which is cut. Level 2 is deep to the pectoralis minor muscle, while level 3 is medial to the pectoralis minor muscle. So the level 1 includes your subscapular or posterior group, your external mammary or your anterior group, and your axillary vein or lateral group. Those that are deep to the pectoralis minor muscle include your central group and your interpectoral group or your rotor nodes. And for level 3, the medial, they're found again medial to the pectoralis minor. They include your apical or supraclavicular group. So again, breast adenocarcinoma. These are the clinical manifestations of late-stage cancer. So you have nipple retraction. So nipple retraction is caused by pulling of the lactiferous ducts because of cancer destroying the tissue. So this is not because of destruction of the Cooper's ligaments. What happens when the Cooper's ligaments are destroyed or shortened is skin dimpling. So dito siya sa may other areas, not the nipple. Kasi nga 'di ba, the Cooper's ligaments attach the breast tissue to the dermis. So ito yung nangyayari kapag nag-shorten siya, nagde-dimpling yung skin. Pudiorange happens when there is lymph drainage from micro embolisms of cancer cells into the lymph vessels. So what happens is that there's thickened leather-like appearance of the skin. Some injuries after radical mastectomy. So when you remove the entire breast tissue and as well as the pectoralis minor and all the lymph nodes, etc., there can be some nerves which are damaged. So, for example, if you damage the long thoracic nerve, since it innervates your serratus anterior, you have scapular winging. If you injure the thoracodorsal nerve, it innervates your latissimus dorsi, so there's difficulty in adduction, extension, and rotation of the arm. If you injure the medial pectoral nerve, which innervates your pectoralis major, then there's difficulty in flexion, adduction, and medial rotation of the arm. If you injure an intercostal nerve, then you lose sensation on the upper inner aspect of the arm, especially if this is your second intercostal, because it has your costobrachial nerve. And last, we have the diaphragm. So the diaphragm arises from the xiphoid process, which is at T10. The lower 6 costal cartilages, L1 to L3 for the right crus of the diaphragm, and L1 to L2 vertebra for the left crus of the diaphragm. So the innervation of the diaphragm, its motor is from the phrenic nerve. Again, it's the only motor nerve supply of the diaphragm. It's sensory. Yung central part is the phrenic nerve, but sa periphery, it's your intercostal nerves. So just one last thing that's very important for the diaphragm is are the diaphragmatic apertures. So you have three. You have your caval, esophageal, and aortic. So the location of the caval hiatus is at the central tendon. It's at the level of T8. The esophageal hiatus is at the muscular part of the diaphragm at the level of T10, while the aortic hiatus is between the two crura, the left and right crus, at the level of T12. So the caval opening transmits your inferior vena cava, kaya siya caval, and your right phrenic nerve. Your esophageal hiatus, of course, transmits your esophagus, your vagus nerve, and some sympathetic nerve branches. Your aortic hiatus transmits your aorta, your thoracic duct, and your azygos and hemiazygos veins. So one useful mnemonic is I ate 10 eggs at 12 a.m. So I ate 10 eggs at 12 a.m. So IVC at T8, esophagus at T10, and the aorta at T12. So that's it for the thorax.